Wilson's disease, I'm going to assume that the diagnosis has been made. So I'm not going to talk to you about how to make a diagnosis because in 12 minutes I can't cover that. However, what you need to know is a survey was taken out very recently in the Euro-Wilsons, which is a group of large number of European centers, asked how do you treat a child, how do you treat a person, not only a child, this is primarily adult with Wilson's disease. And this was the answer that you got. Some said penicillamine, some said zinc plus penicillamine, some said trientine, etc., etc. Then they were asked, why do you do that? And these were the sort of answers that you got from reasonably very good centers from the Euro-Wilson registry. So as you can see over here, how I treat Wilson's disease may not be how someone else treats Wilson's disease. But what I'm going to do is, most of us follow standard guidelines, and that's the thing that I'm going to talk to you about today. So let's come into the management directly. What is the role of diet? Well, we think diet has a role, primarily as an adjunct, not to the main therapy, and usually for the first year or two of life, not lifelong. So what our dietitians or nutritionists do is they divide all the foodstuffs into three types. Those who have got less than 1, 0.1, 0.2 and more than 0.2 per serving. And they tell the patient more than 0.2 is avoid, less than 0.1 you take, and 0.1 to 0.2 is what you take in moderation. That's important. You also need to remember about water. If your patient is taking well water at home because he's from the village, well water has been known to contain high amounts of copper, you have to be careful. Second question that is asked is, what about Bisleri, Kinleys and all those typical mineral waters that you get? An excellent paper in 2010, and I think one of the journals, I don't remember which one, but I have an abstract, which looked at 8 common good preparations which have got mineral water, and all of them had contained less than 0.05 milligram per liter of copper, extremely low levels of copper. We used to tell people initially, avoid taking mineral water, but you don't need to do that because the copper content of mineral water, the standard ones which we all use, are extremely very low. So these are the couple of points that we tell our parents, but I'm not going to talk too much about the diet. Obviously, you avoid the ones which are very high, and the commonest thing that we talk about is chocolate and dry fruits, which are important, and liver meats. But besides that, there's a lot of Indian other diets which are important. The medications which are in armamentarium are primarily 3: penicillamine, trientine, and zinc. Ammonium molybdate has still a long way to go to be easily available, so we are not going to talk about that today. What do we do when we give the treatment? What we do is we give initial treatment to reduce the copper to a subtoxic threshold, that is between 6 to 12 months, and the two commonest drugs, primarily D-penicillamine but also trientine. And after you have reduced it, you require something to maintain that, and that is either D-penicillamine, trientine, and there is where zinc comes, and that is to be taken lifelong. These are the 3 groups available to us. Penicillamine and trientine are chelators. Penicillamine is easily available in the Indian market, reasonable cost, has its side effects, and if you see the list of side effects, there are many, and primarily is the deterioration in neurological function in those who are neurological Wilson's disease, not so much of a problem in liver disease. It has its own problems there. As compared to that, trientine has got much lesser side effects, not to say it doesn't have, but it has much fewer side effects, and we have had not, in our experience, we have not had to stop trientine because of any side effects wherever we have used them, and that's quite a few. The problem is it's extremely expensive, and every year it gets more and more expensive, and it's now almost become prohibitive. So most of our patients who have been on trientine for a longish period of time have in fact now stopped taking trientine only for the reason of the costs. It was expensive to start with, and it's now extremely expensive. Zinc is not a chelator, so it induces metallothionein, it causes stool losses of zinc, easily available, reasonably cheap, very few side effects except for gastric discomfort. So where do you use what? We don't have liver transplant in our center. We have just done our first liver transplant, but we don't have a program. So what do we do, or what should be done if you have liver transplant with encephalopathy? Obviously, this child requires a transplant. Go for a transplant quickly. In the meantime, you may or may not use trientine plus zinc. Quite a few people would use zinc. If you do not have encephalopathy, you would try to decide whether this child requires a transplant or can be controlled only on the basis of medicines. And the way to do that is to use the modified King score, a well-published score, which tells you whether this child is a child to be put forward for a liver transplant or can be treated. The lower group, that is those who have got asymptomatic transaminases or those who are asymptomatic and normal LFTs. And this is quite being picked up now and now as you start screening siblings. So when you pick up siblings of Wilson's disease, they are asymptomatic, their liver functions may be very normal. You would generally treat them on zinc if you get a good quality zinc. And the problem is good quality zinc. You have to be assured that the zinc you are giving the child actually has the zinc. And the reason why I'm saying is there were preparations in the market a few years ago which said 250 milligrams of zinc sulfate which contains zero zinc. And we have experience on that. So you have to be very careful that you use the appropriate zinc. And this is very serious because if you put a patient off penicillamine onto zinc and that zinc is not there, this patient is going to deteriorate. What is not answered is two questions. Because of the genetic haplotype analysis, if you have one sibling with Wilson's disease, you can now tell quite often if a newborn second sibling to the child in the first month of life has Wilson's based on genetics. Now what do? He has the same haplotype as, or he has the same mutation as your sibling who has Wilson's, but he's just 1 month old. Do we start him on zinc? Should he start it at 1 year? Should he start it at 2 years, 3 years? That answer we do not have today. Luckily, there are fewer cases that way. So what we generally wait till they are 2 or 3 years old and put them on zinc. But there are no definite guidelines for that, or the guidelines are controversial. What about a classic case that all of us see? The chronic liver disease, or this child that we saw just now. Chronic liver disease with zinc, with Wilson's disease. What do? We said we have 3 treatments, penicillamine, trientine and zinc. Do we use one, do we use 2, or do we use the combination? This is what I do. Almost all our patients I treat with D-penicillamine and zinc together. D-penicillamine twice a day or thrice a day, zinc once or twice a day. I try and make an effort not to give more than 4 times a day of D-penicillamine and zinc. So either 2 D-penicillamine and 2 zinc or 3 D-penicillamine and 1 zinc. The idea being D-penicillamine and zinc have to be given on an empty stomach, both of them. And both of them have to be kept apart 5 or 6 hours. They cannot be given together. Otherwise penicillamine binds the zinc. Neither the zinc will work nor the penicillamine will work. So it's compliance wise, you can only give it every 6 hours, 4 times a day. So if I'm using 3 D-penicillamine, I use 1 zinc. If I'm using 2 D-penicillamine, I use 2 zinc. That's what I personally do. Except in the situation of neurological, which we are not going to talk today, but I see a lot of neurological Wilson's, where the patient is affording, I give them a choice of taking trientine and zinc together. But as I said, the costs have become tremendously more. When you get D-penicillamine intolerance, and we will talk about that, then is the second time when we think of trientine or zinc. Zinc as the initial treatment in a chronic liver disease is not to be used as far as possible. There have been occasional studies, but let's say generally if a child comes to you for the first time, use penicillamine. If not, use trientine or occasionally, or using when either it's a pre-symptomatic child or the child has been well treated, and we will talk about the well treated later. You also need to know, because most of our children are now grown up and become pregnant, and now you need to decide when when the patient is pregnant, what do you do? First is, do not stop the treatment. You can use really any of the 3 that the patient is already taking. Zinc is of course by the safest, but it is not an absolute must. If the child is also on penicillamine, you can continue that. There are an occasional reports which have reported problems with penicillamine, but generally it is a reasonably safe. However, towards the 3rd trimester or the end of the 2nd trimester, early 3rd trimester, reduce the doses for 2 reasons. You don't want the baby to get copper deficient, and D-penicillamine has a lot of problems with wound healing. It prevents wound healing. If that mother is to go on for a cesarean section, you generally want to be safe and not give very high doses of penicillamine. There's not much scientific evidence behind this, but this is what more and more authorities are doing all over the world. It may change as time goes on. What about monitoring? We have to monitor for various reasons. And really the monitoring first is monitoring to find out if the child is getting better. And second is to monitor if the patient is developing any side effects. And this holds specifically true of penicillamine. So this is what we generally follow. You do a clinical monitoring, this is biochemical, and you do a urinary copper estimation, especially when you're using one of the chelators. What do you expect clinically? Please do not expect your liver functions to get better overnight or within 4 to 6 weeks. It takes 2 to 6 months for your liver functions to normalize. Sometimes it takes as long as a year. So you have to be patient. Follow up the child very regularly. KF rings can take as long as 5 years to go. So be careful about your KF rings. You don't need to be worried about if it doesn't go in a couple of years. Sometimes it may go. It all depends on how big was the KF ring to start with. Was it a very faint one? Was it only restricted to the upper and lower, or was it a dense KF ring? The denser it is, the more longer it will take to go away. And the urinary copper is something that you need to estimate very, very regularly. These are the side effects that you normally see. As you can see, penicillamine has the most side effects. If you get early, these are the ones that come in first 1 to 3 weeks. And if you get any of these, fever, rash, bone marrow suppression, proteinuria, or lymphadenopathy, you have to stop. In the West, they will stop penicillamine and go on to trientine. If you don't have trientine, you can still follow what was followed 20 years ago in the West. Stop penicillamine till the problem goes away. Restart penicillamine either with very low doses or under cover of steroids. We have done that in a few patients, and it has worked. Patients who could not tolerate penicillamine initially have now started tolerating penicillamine when you start under the cover of steroids, if you have this problem. But you have to stop it at that particular time. When you have problems of late toxicity like nephrotoxicity, you have these problems, these lesions. Now you are seeing more and more children coming to us with these typical lesions of EPS. These are all penicillamine induced. We used to think they would stop after stopping penicillamine. There's people who have stopped penicillamine and are on zinc, but the lesions are keeping on occurring. And they are all over the neck, the body sometimes. And this is something that you will see the longer you use penicillamine. Lastly is just a word about the urinary copper. All of us follow them up with urinary copper. Do we really know what we are looking at? And that's something I want all of you to listen. When you put a child on penicillamine and urinary copper, your urinary copper goes up very high. Over a period of time, it comes down and settles down. So you know the child is in negative copper balance. And for that, the urinary coppers are 200 to 500. Urinary coppers will not come down to less than 100. So when they say a normal range less than 100 or less than 150, when a patient is on chelator throughout his life, his urinary copper should be in 200 to 500. If in fact it starts dropping below 200 or 100 when he's taking the full dose of chelators, you are actually going and over-treating the child, and the child is in copper deficiency. So your normal level should be 200 to 500. What tends to happen if the patient is not compliant? If the patient is not compliant, two things will happen. One thing will happen is that once you give that, what happens is he doesn't take, that's why the chelator is not removing the copper levels are very low. Or what we see very often is he's not taken for 6-7 months, but he knows that he's coming for a visit to KEM. 1 week before that he will start retaking because he knows we are doing the test. And you will get copper values of 500, 600 and 700 and 800. Very high copper values because he's not taken for a long time and suddenly he's taken. Both of them are non-compliance. Low level because he's not taking right now, or very high, and it's sometimes important for you to differentiate that. And there are two ways of differentiating, either looking at the serum-free copper. If the serum-free copper is more than 15, it means that it's a non-compliance. But the simplest way to do it, and which is now recommended by Wilson, is annually stop penicillamine for 48 hours. Do a urinary copper. If the urinary copper is less than 100, the patient is well treated. If the urinary copper is more than 100, patient is non-compliant. That is the test that you can do, but you have to stop 48 hours penicillamine. Last point I want to make is this is all very good for trientine because they are chelators. But if your patient is on zinc, you have completely different values. In zinc, your value should be very low actually. So good control here, urinary copper should be less than 100. If your urinary copper is high, because it's not chelating, it is coming down itself. So the interpretation of urinary copper depends on medicines that is being taken, compliance, non-compliance, and it's a little difficult to understand, but once you are into it, it becomes very easy. So unless you know that, you really don't know what you're doing when you're following up, because urinary copper is the only reasonably good test that you have to monitor. So to summarize, chelators are the mainstay of treatment. Diet has a limited role, but yes, we do it for the first year. Zinc is more for long term. Please monitor and please try to understand the 24-hour urinary copper interpretation before you make any dose adjustments. Thank you.
Very good talk, Dr. Ashish. Just one comment that agreed trientine is a better drug to give, but for the vast majority of our patients, given the cost and inaccessibility to this drug, we still continue to use D-penicillamine as our first line in majority of our patients. And I must say that if they are monitored well, it is not as bad a drug as it is made out to be. So, so you do the counts, Don't do just a urinary copper, do a 24-hour urine protein. I mean, this is often left out. And explain the side effects of skin, etc. to the patient. I think you are still able to manage about 90% of patients without any major problems, and switch over to zinc when you think they are adequately chelated. This is what I would say.
Yeah, when you're looking at neurological also, there are some problems that we are seeing and we have been seeing. So it's slightly more of a problem.
Yeah.
You have to just start very lower dose, but we have seen, I mean, to my mind, you see a child with Wilson's disease who has come walking to your clinic, you have hospitalized him, made a diagnosis, put him on penicillamine, and he's gone bedridden outside.
Yeah, that is because he started on full dose. In neurology...
No, we don't start on full dose.
No,
we start on 5 milligram per kilogram, increase it very, very slowly, but still they will deteriorate. And remember, they will deteriorate and remain worse off sometimes than what they were before. So, it's a cost problem. If it's affordable, finally, what do the guidelines say? Whole of US uses Trantine, they don't believe in penicillamine. Europe says penicillamine is still the best.
Yeah.
No head-to-head trials.
No,
so
but for our country,
what you're comfortable with, you should use. Yeah. But monitoring is very crucial, as you said.
Ashish, what about the combination therapy? What do we monitor in that?
The chelators. Forget the zinc when you're looking at the combination therapy. Zinc, you don't need to worry about the zinc. Just look at the right-hand column because the chelators that affecting the urinary column.
Sir, how do you differentiate between a patient who has deteriorated neurologically due to DPEN versus a person who has is having a progressive Wilson's, who has added on a neurological component? Do you do a baseline MRI in non-neurological Wilson's?
No, why? You can see clinically in front of you, when he's progressing slowly.
Yes.
When you put him on depenicillamine, you put him in your ward, you see him progressing.
Sometimes, sir, the deterioration comes much later.
No, deterioration, if it's going to come much later, you're not worried about that. The depenicillamine neurological worsening usually comes very early. Very early. In front of your eyes, you will see in the first couple of weeks, 3 weeks, 4 weeks, you will deteriorate.
And how slowly do you increase your DPEN?
That's what I said. We start with 5 mg per kg.
No, over how much period?
Every 5 days, if it's a neurological.
Okay.
If it's a neurological. It all depends on how severe the neurological is. It's individual. I don't have a specific protocol, but if I find that this child is significantly neurological involvement and is going to stay with me, then I use it. If it's going to stay in Pune, I do it every 7 days. But once you're neurological, you're not too worried about starting very, very rapid and going up to high. In liver, you are worried because they come to you in a liver problem which is going to deteriorate. You want to step up to the maximum dose reasonably quickly to start its treatment. So in neurological, anyway, forget neurological or even I start every 3 or 4 days, I increase the dose. Every 4th day, that's the protocol.
Can you elaborate upon the steroid use you had mentioned in one of the slides?
Yeah, it's an occasional
because we've not come across it in literature that well, so that's why.
Oh, there is enough literature. You look at old Wilsons, they all said give steroids. Enough literature, reviews.
Stop deep and give steroids.
Stop depenicillamine, wait for the hypersensitivity problems to get over, restart them under cover of 2 mg per kg of steroids. Even in adults, enough literature. It's no longer done because people now easily use Trantine in the West. Okay. So if you don't have Trantine, what do? On one side you have to use penicillamine, on the other side you can't use penicillamine. So try steroids.
And steroids are given over for how
long? For the
long?
first 4 weeks, that's all. It's not that always you'll get over, but quite often you'll find it acute because basically the immediate ones are acute hypersensitivity. So under cover of steroids, quite often they will tolerate and later on you may not need to do that.
Ashish,
and there is enough evidence.
Ashish, Suchi, like you said, there are not many trials available. What Suchi writes, even in the latest one, is that you give zinc 50 milligram TDS and 1 or 2 doses of DPEN. So what we're doing is we're giving 1 of DPEN and 3 of zinc. Is that okay?
In the initial part of it, I would be more keen to give chelators. I'm very frank, I'll tell you very clean. You have to use chelators initially with our background of zinc problems. Or, I forgot to make a point, if you are worried about your compliance of the zinc that you're using, measure the 24-hour urinary zinc. Like you send your urine for 24-hour urinary copper, measure the 24-hour urinary zinc. If it is more than 2 milligrams per day, you are giving good zinc to the child. If the child is taking medicines and your urinary zinc is very low, less than 2 milligrams, there is no zinc in that preparation or not adequate zinc in that preparation. So it's not very difficult to find out whether that medicine, you don't have to actually measure the zinc in the tablet or a capsule.
Dr. Ashish, a couple of points. Acute liver failure, I noticed you didn't mention depenicillamine. Yeah. And acute liver failure, this abstract was published 2 years ago at ASLD, and they asked all European hepatologists, including some US ones, how they would treat. Some of them they said they would give depenicillamine, some of them said they did not give depenicillamine. But when I tried to publish my paper, and I know that some pediatricians don't like to give depenicillamine, I like to give deep penicillin even though they have acute liver failure. So there is no clear-cut answer as to whether you should treat with deep penicillin or not with acute liver failure. Because the second point I had to make was all models, whether it's King's College model, revised King's College model, everything works very well when it's done in that institution. And so that has to be taken. Then that's what published us to write this paper. And again, anything that goes a little contrary to what is published in Western literature, it's extremely difficult to publish. Because there's a coterie which doesn't just allow you to get in. Now, when we did that, we had the largest number of acute liver failures in the entire world. We had 230 patients, of which 61 were children with acute liver failure. And we found that the ROC for King's College criteria was 0.78. Revised King's College was about 0.79. MELD score, which is again a good score, is about 0.78, and our own score about 0.781. So they all work very well. The answer is which one is a good one? Take your pick. Whichever you feel is comfortable, you do it.
Absolutely. The point is that at that situation, you have to find out whether doing a transplant is going to be beneficial to the child, or is this child going to recover by medicines. You don't want to put a child who is going to recover and do a transplant or the other way around. So you have some score or some scoring system to help you decide. It's not going to be a perfect scoring system, but it's something that you follow.
And one final point I want to make, the genetic mutations that occur in Indians are absolutely different from what occurs in the US. 1069Q does not occur in Indians at all. Indians have a different kind of genetic mutation. So we find that our Wilson disease are a different kind of patient. They're much more severe. They present much more faster, very progressive disease, males more than females. So I think my only plea is, after having listened to all this, is look at your Wilson disease patients properly, work them up and find that there are differences and and conglomerate all the cases and get them published.
Yeah, forget even India, forget even the world. There are 6 mutations in West Bengal which are responsible for 44% of their Wilson's disease. Then we wrote a collaborative paper with them, and only 7% of those which are responsible for 44% are those of Western India. So forget West, and even within the country we have North-South divide. When we discuss this with the PGI group, they have their own mutations. So mutation analysis is not something. If you have to do it, you have to do a full sequence.
In total about 55 mutations from India itself.
Oh yeah, there are going to be many mutations. So don't send a patient for Wilson's disease for mutation analysis. Use your workup, which has been told to you about ceruloplasmin, urinary copper, KF ring, etc. That is still the best, and hepatic copper. That is haplotype. That's a haplotype. That's a different matter. Thank you.